Welcome to Gracefully Greying. I am your host, Attorney Henry Gorenthine. We are now continuing a conversation that I've been having with Dr. Neepa Patel with regard to Parkinson's, which is really the majority of your practice, Dr. Patel, and we've been talking about really some of the symptoms. We're getting to some of the treatment. I'd like to talk a little bit more about some of the symptoms and just some of the programs you devise for patients to fight it, for lack of a better word. And first of all, what about choking and swallowing issues?
Sure. So, choking and swallowing issues can develop in Parkinson's over time. So the first thing that I tell most of my patients to do early and often is, in addition to physical therapy, is speech therapy. Not only helps them maintain their voice, which can get softer over time, but we've found, research has shown that practicing these vocal exercises can actually improve swallowing function. So we talk about it often, and as our patients are commenting that they're having a little bit harder time with swallowing, we'll send them for speech therapy evaluations, teach them techniques. The therapist will teach them techniques on how to modify their diet and improve their swallow function. At a certain point, we may have to start changing food textures and other things to help improve their swallow function and keep things as safe as we can.
Should they eat more slowly and perhaps cut things into smaller pieces?
Absolutely. Both of those is the starting point of that, which is cutting up food into much smaller bites, chewing longer. Sometimes sipping a little bit of water can also help it go down a little bit easier as well.
We talked about some of the major medications that you prescribe. What are some of the side effects that our viewers should be aware of?
Yeah, so most of the side effects related to the medications are related to the dose. So lower doses may have less side effects, higher doses will probably have more side effects. The most common, I'll talk about carbidopa levodopa because that's truthfully the most commonly prescribed medication. That medication, nausea and vomiting, is probably the most common side effect that people will experience. This is not a side effect that will be there forever. For most people, we can come up with strategies to manage that, eating food with their medications, titrating up much slower, and most people will, over time, get used to it. Other side effects include lightheadedness, dizziness, and specifically, the medicine over time may lower your blood pressure and cause drops in your blood pressure as you go from sitting to standing, which sometimes can, in its own way, affect balance. Other side effects are rarer but can happen, would be, well, dyskinesias is a common side effect that happens as Parkinson's progresses. So early into Parkinson's, this is not a common symptom, but later into Parkinson's, we expect Parkinson's patients to experience a twisting, turning, abnormal, wiggling movement, kind of like what Michael J. Fox shows. These are irregular, random movements that happen in response to medication. And this is a very Parkinson-specific problem, so we believe it's the way a Parkinson's brain handles the medication rather than the medication, causing damage or injury to the brain. And then lastly, in older patients that may have memory difficulties, hallucinations can be another problem that develop with these medications. But hallucinations can also be part of the picture of advanced Parkinson's disease.
Can advanced Parkinson's lead to Alzheimer's and dementia? Is there any relationship or correlation with these?
So that is a very good question. I don't think we've sorted it out exactly. So Parkinson's is related to a memory cognitive disorder. And can be progressive. The problems in Parkinson's related memory changes have more to do with organization and planning of information. So, kind of sequencing out the steps to complete a task. If I want to go get some groceries, get some gas, and go pick up dry cleaning, sorting out what order to do it in and remembering, you know, what you have to do in between each step to get there is really hard to do. Alzheimer's is a condition that we think about more as losing your details, the memories of who you are as a person, information that's given to you directly. There is a lot of overlapping features between the two, and it's hard to say if they're two separate processes or part of the same bigger picture.
Let's say you have a patient, you've diagnosed Parkinson's, we've talked about medication, we talked about, let's talk about what type of program you design, and I'm sure every person's program is different because we're talking about a very individualized disease, for lack of a better word.
Yes, so the first thing we talk about is what are my patient-specific goals. So I'm going to treat a younger patient who's still working, maybe has a family that they're running around after, as opposed to an older patient who's retired, empty nester. They have different goals. My 70-year-old who's retired doesn't have to, you know, work 8 hours and then come home and cook and clean and do all their chores and help out with the family, whereas my younger patients do. So I tend to be slightly more aggressive in symptom control for my younger patients.
Tell us about your program there. And
yeah.
Another question before, isn't exhaustion a major factor with Parkinson's as well?
Yeah, so fatigue and exhaustion is a problem in Parkinson's, primarily because of the nature of the condition, but also because it's harder to accomplish all your day-to-day tasks. So the way I describe it is, with Parkinson's, you're kind of walking through water all the time. And we're changing, you know, the consistency of that water, trying to turn it back into air, which is easier to move through, by using the medication. So for a younger patient, I may be using 3 different medications in combination to try to keep them on a smooth, even course. We're considering not only their movements, but also some of their non-motor symptoms, if they have mood issues, constipation, various other complications. And just the rates at which I scale up the medication or push the dosing really depends on the individual and their goals out of the treatment, and if I think their symptoms are going to be responsive. Certain symptoms of Parkinson's are not as responsive to the medication. It's hard to give you a prescription because we don't really have a recipe. So I usually will start out with either carbidopa, levodopa, or if somebody has milder symptoms, one of the earlier add-on medications or derivative medications like a dopamine agonist or an MAO-B inhibitor.
What about exercise? How important is that?
I think it's one of the most important things. So that is what I tell all of my patients wherever they come to me with their Parkinson's, is to get on a really good exercise program. I usually start off with physical therapy, and the therapist will work with the individual on strengthening up areas that might be weak or need a little bit more attention for them. And then I have them work up to trying to exercise for at least an hour a day. 5 days a week, but I always say 7 is better. And this can be a combination of it should be a combination of at least half of that time doing cardio, so working up a sweat, getting your heart rate going, as long as your heart can handle it.
What if someone does cardio and doesn't work up a sweat? Is there any reason for that, tied in with Parkinson's?
I would say it's probably because they're not vigorous enough. Now, you know, a 40-year-old, I'm going to have them be much more vigorous than I am an 80-year-old. So we're putting things in perspective. But a leisurely walk at the end of the day is not bad, but it's not the aggressive cardio that we're talking about in terms of exercise. And the other important part of this, the other half of that time should be on stretching and strengthening. And that's a whole body exercise program that, you know, primarily works at low weights and high repetition type exercises. Yoga, Pilates, Tai Chi, boxing are a variety of different strategies.
So yoga is very important. And boxing, you mentioned. I know there have been boxing studios open that really center around Parkinson's.
Yeah. So
And how does that work exactly? I mean, you're
yeah. So the first part about just the whole body exercises, what I tell people is pick something they like and that they connect to, because they've got to do it every day, and it's got to work you out from head to toe. The boxing has really picked up, I think, throughout the country as a Parkinson's focused strategy of not only bringing positive attitude and energy, but a really good workout program. This is non-physical, non-contact boxing. So what they're doing is a lot of stretching, strengthening, cardio, stamina building. And the nice part about boxing is you have to quickly and agilely move. So you go from one position to another position. So it really works on the things that are breaking down in Parkinson's, which is coordination. And they have it's really fun and upbeat, and a way for Parkinson's patients to meet in a positive community.
What happens when Parkinson's starts progressing and the pills no longer are working very well? What do you do in those situations?
So the pills typically work, they just tend to not work as well, and we cannot maintain the good therapeutic benefit for as long as we would like, or they may have side effects.
So you're upping the doses and you're balancing between helping fight the disease, but also what are the side effects?
Exactly.
So the higher the doses, the more side effects are
exactly. So in those cases, we start thinking about alternate strategies, such as the pump, Duopa, to help stabilize the level of levodopa. Total, we can lower the total amount of levodopa, but still give a steady state, so we can stabilize the symptom control that way. And then deep brain stimulation is another strategy that we use.
Let's talk about that.
Yeah.
I mean, it's DBS, deep brain surgery, stimulate. It's surgery.
It is.
So,
it's brain surgery.
So tell us about that.
So this is a brain surgery, as I mentioned, and for simplicity's sake, it's like putting a pacemaker into the brain. It is a wire that goes into the basal ganglia, so the deep nuclei of your brain, that helps with coordination. And there's two big targets that we pick in Parkinson's disease, and I'm not going to talk a lot about why we pick one over the other, but your doctors and your team will kind of decide what's best with you based on your goals, your interests, and your specific problems. And then we implant the electrode into the brain. That's done by a neurosurgeon. And then it's connected by a wire under the skin to usually the chest, where there's a pacemaker implanted. And then we program it, so we're delivering electricity into the brain, and that helps to stabilize the symptom control. And we still don't fully understand how it works, but we believe that it's bypassing the break in the network. And part of that break is that dopamine helps move the circuit forward in controlling your movements and regulating the balance of movements. And so as you're making less dopamine and you're giving too much or too little by the pills, we can just bypass that and kind of create the circuit, kind of bypass the circuit and keep it moving forward.
Now, in some DBS surgical procedures, aren't there two?
So typically in Parkinson's, we do both sides because Parkinson's affects both sides.
Okay.
Parkinson's typically starts on one side of the body and then progresses to the other. So rarely somebody may just be really severely affected on one side, and we really don't see much on the other. Then we might go in and do one side first and wait for the other one. But typically we just implant both because it's a little safer.
And how many surgical procedures are typically done? I know the first one is where you're implanting the electrodes in the brain, but then you're running wires under the skin and either to the chest or the abdomen.
So it depends per center, so I'll just talk about ours. We usually do it in two stages. The first part will be the brain surgery, and then the electrodes are implanted, the caps are put in, and then on a separate surgery about 2 weeks later, we take the extension wire and we snake it down to the chest wall or the abdomen and connect the pacemaker. So for us, we do it in two surgeries. Some centers may do 3, other centers may do 1, and there's a lot of factors that go into that.
But typically you do
Typically 2, yeah.
Because I've heard 3. two. I've never heard of one. So
yeah, one has gone by the wayside because it's a very long day for our patients. So we found that it's a little safer to break it up into two separate surgeries.
And how long the surgery's done,
Mm-hmm.
and then there's a whole procedure because you start the programming.
Mm-hmm.
And this is something, you don't do the surgery per se.
I don't do the surgery. A neurosurgeon will implant
Right.
the device. And so after the brain surgery, about a month on average, we will bring you back to clinic to turn on the stimulator and adjust the programming for it.
And how does that work? I know, what do you sit there with a little
Mm-hmm.
iPad or computer and you're working away to get the right combination, so to speak, or
Yeah.
explain it to us.
So there's a few different strategies, and I think each person who works with the device has their way of doing it. So I'll speak to the way I found to be most effective
Okay.
for me. So usually when we implant the device, there's 4 electrodes on each wire. So there's 4 here and 4 here. And we'll just test it out. We'll introduce electricity at the bottom contact and kind of scale it up to the maximum limits or until we run into some side effects, because electricity in the brain not only affects the area we want, but some surrounding structures that we don't want to. So we'll test out, we'll kind of find the limits to where I can use that electrode, then we'll move to the next one and do the same thing, do the next one and do the next one. And so usually we'll test out 8 electrode points, and there's a lot of different variability within the system, so it's not perfectly that way each time, just because some systems have more contact points and other components to it. Once we kind of find the area that has the biggest window of benefit with the least amount of side effects, I usually start there and I introduce a little bit of stimulation. And then let them go home and we start kind of trying to adjust their medications, see if we can cut down on anything or just let them stabilize. And what I tell most of my patients is it takes about 6 months, sometimes longer, sometimes shorter, to kind of hit the new steady state, find out the right combination of medications for you and to help all those symptoms that you've been struggling with just kind of regulate or normalize.
Can the surgery result in someone having no medications?
Rarely. It's not the goal of surgery, and I think it would be unrealistic to tell all our patients that they can get away with no medications, but sometimes for the right patient we can get them down or off medications quite substantially.
Can there be personality changes caused by the surgery?
That is a potential risk. So we are going deep, about 30 millimeters deep into the brain, and so we're crossing through a lot of other areas. Now we've learned a lot about the brain over the years, and we know certain angles will avoid the major centers like your speech and big memory areas and things like that, and motor control so that you don't have weakness. But it can cause subtle changes in thinking and memory and personality, so we're always on the lookout for it. It's not common.
What about speech? Can it impact upon speech?
Yes, so stimulation, one of the side effects for, depending on the target, but typically can cause strain, a kind of a strain in somebody's speech. We can sometimes program around it, but if it's providing really good benefit and they're able to communicate, sometimes we are stuck with just a little bit of straining of their speech.
Are there any other side effects of DBS surgery?
So a lot of the benefits and the side effects are related to where that probe is inserted. So the closer we are to the ideal location, the less likely chance of developing side effects, and the more opportunity of getting the best results. So a lot of the side effects are dependent on where that electrode goes, and so I rely on my neurosurgeons to try to get it in the best possible location. So some things that I have seen, in addition to speech changes, would be facial pulling. Sometimes if we give too much stimulation, we'll see kind of cramping or spasming on a face, or the arm cramps or spasms. Sometimes we can affect walking and balance with stimulation itself. So it's something that I'm always looking out for to make sure that I haven't worsened somebody's balance. Depending on the location that we go to, we can sometimes worsen the dyskinesias, those twisting, turning, wiggling movements. Now, for most people, if there's a slight worsening in the beginning, it kind of settles down over time. But rarely, I've had a few patients that the stimulation makes the dyskinesias worse, and we are limited by how much we can use because it's not settling down.
Now, when it works well, doesn't it, one of the goals, I know it's not a cure, but doesn't it set the clock back? That's what I've heard.
Well, so setting the clock back, it's tricky. So we're not reversing Parkinson's. If you were to turn the device off, the symptoms would come back.
Exactly.
But what it does is it masks, or it puts it's a really sophisticated Band-Aid to the symptoms. So yes, we can improve a lot of symptoms, and we can stabilize a lot of symptoms, and we can reduce the medication so you're experiencing less side effects.
What percentage of your patients have DBS? Is it fairly common now, or is it still more the exception than the rule?
So the kind of standards of care in Parkinson's, deep brain stimulation is part of that care. I would say my population is a little biased because I am one of the main programmers in our group, so there's 2 or 3 of us that do this, and I have kind of built up an expertise. So I would say at least about 15% of our patients, of my patients, have DBS, and every year more and more are headed towards that. So it just kind of depends on when I meet you and when you're ready for it.
And isn't it true that there's kind of a window, and if you wait too long, it's less effective, and so you're trying to time things?
Yeah. So that window is not just 1 year or 2 years. It's a broad window, but yes, there is a certain time period in which you can get the most benefits out of it. What I always talk about with my patients is 3 things that I'm always considering. 1, I want you to be doing well, because the better you use your body today, the better you will have it for tomorrow when you're progressing and aging. So if you're waiting until you're really desperate to have the surgery, we have a long way to go back to, and we may not get you back to that kind of great spot that you hear about with some patients. The other is as you age, you can have more what we call levodopa resistant symptoms. So balance is one of those tricky things, and memory is the other one, where levodopa doesn't always help. And so if levodopa doesn't help the symptoms, neither does DBS. And so if we implant DBS before you develop levodopa resistant symptoms, you have a longer opportunity to get benefit out of it, good benefit out of it. And those symptoms will eventually develop, but we would probably not consider DBS in somebody who's falling all the time, irregardless of medication. And we would not consider it because the surgery itself can affect walking and balance more, and we cannot consider it in somebody who has pretty significant cognitive impairment or has dementia. So we want to get it in people before they develop those problems, because then we can still gain the benefits of reducing dyskinesias, improving tremor, helping the muscles relax, and helping to stabilize the medication benefits.
What about driving?
That is a very tricky question. So
Okay.
Parkinson's does affect driving, and it affects driving in a few different ways. So it's a condition of slowness. So one, people with Parkinson's have a slower reaction time. And when you're driving a car, you're getting information rapidly, and you have to make split-second decisions. So even though your mind might be able to make that split-second decision, your body doesn't always make that decision in a timely manner. And so that could be the matter of braking when somebody runs out in front of you, or the car in front of you brakes. And so people are at higher risk for getting into accidents. The other trickier part of this is that also memory is a huge part of driving. You have to be able to process information that's coming at you rapidly. And so for those reasons, I look at 2 things, which is we do every now and again just a cognitive assessment. And if I'm starting to show concerns that your thinking and memory may not be able to handle driving, we talk about it. more often than not, family members bring it to my attention and say, I was in a car with them, I'm really concerned they're not driving safely. And so what I prefer to do is have you take a driving safety evaluation. You can do that through the DMV or through occupational therapy. And somebody will get in a car with you and drive with you. And if you pass, you know, just like when you're 16, if you pass, we let you drive for a year and then you get a reassessment. But very often you may not pass, and then that usually means you should not be driving anymore.
Dr. Patel, how does someone embrace Parkinson's? Or, you know, it's like you make lemonade out of lemons. How does someone find the positive within it? And this is something you mentioned. Let's talk about it now as we wind down the show.
So I think as we age, our bodies, for a variety of different things, from arthritis to just wear and tear injuries to the body, our body ages and we don't always do well. The way I look at Parkinson's is, yes, it is a degenerative process. Yes, it does cause disabilities and sometimes memory problems. But this is a condition where we have a lot of therapies and strategies to put a Band-Aid to it, to improve you for periods of time. And so rather than, you know, being down and upset about, oh man, I have Parkinson's, say, well, I've got a lot of good opportunities to improve a lot of these symptoms. I can do a lot on my end to help it, exercise being the most important. And the other is just that, you know, life hands us a deck of cards and we don't always know what we're going to get. But if you kind of roll into it rather than hold on to, well, I used to run marathons and now I can't, you know, just kind of embrace the changes that happen and, you know, not get too upset about what used to be and focus on the now. I think those are the most important things.
We're down to about a minute and a half. What are some takeaways for our viewers before we sign off, Dr. Patel?
Yeah, so in talking to patients, I think the things that I hear most about is there is a concern and a fear of taking medications for Parkinson's, that they may do damage to the body. And I think science has really shown that it isn't the medicine causing harm to Parkinson's, but rather Parkinson's and how it manages that medicine over time. It's better to treat early and have you move well and function well, because then you raise the bar from here to here and now you're falling less as opposed to starting here and dropping down. Same goes for deep brain stimulation therapy. I think a lot of patients are terrified of having surgery, and this is a very important component to taking care of Parkinson's long term. Now, it's not right for everybody, but it is certainly something that can help. And the last is, I think, to stay positive. I think there is people who get really down and upset and, you know, live in the past and just wish that they could go backwards in time. And it's really, you know, being where you're at and being a positive role model and making the best out of life.
Make the most of every day, and
exactly.
We don't know what tomorrow will bring.
Enjoy
and
your
also,
family. Yeah.
If you or a family member see some symptoms, contact a doctor sooner than later.
Yeah.
Don't ignore it. Don't put your head in the sand. Dr. Neepa Patel, I want to thank you so much for being my guest on Gracefully Greying.
Yeah.
And I want to thank you for watching Gracefully Greying.